Thank you for tuning into our podcast to learn a little bit more about our 3 recent papers in developmental medicine and child neurology. My name is Theresa Moulton.
And I'm Colleen Peyton, and I present on behalf of our entire team who helped us with these series of papers. So we wanted to talk a little bit about how we kind of got the inspiration for this trio of papers. I'm a physical therapist, and I worked as a clinician for 14 years before changing over to academics. And in my clinical work, I started to discover this idea of measuring selective control in some of my patients with CP. And then when I went to Northwestern, I met Theresa, and she has a different background.
Yeah, I'm also a physical therapist by training and an engineer, and so I did a lot of my work in my PhD thinking about this idea of selectivity in older children and how we can measure it and what does it mean about the brain. So we got a chance to talk and thinking about quantification and observation of movement.
Yeah, and I had some background in the general movement assessment, which is a way to observe infant spontaneous movement and understand about the nervous system. So we combined these two sort of backgrounds along with our colleague Vanessa Barbosa's background in psychometrics to come up with this series of papers.
So selective motor control, sometimes called independent joint control, is the ability to move a single joint at a time. This is a hallmark of the corticospinal system and the ability for a brain area to communicate with a single group of muscles at one point in time. And it can be observed, the health of the brain can be observed through these small, independent joint movements in isolation.
Selective motor control has currently been measured by asking a child with or without cerebral palsy to isolate one joint movement at a time, but this requires them to be able to follow directions. Infant measurements have not been able to do this, and that's why we came up with this idea, and our hypothesis was we wonder if we could observe these movements in an actively moving baby.
The ability to independently isolate a single joint as traditionally measured has been shown to be strongly related with gross and fine motor function in children with cerebral palsy. So this seems to be a very strong marker of the health of the corticospinal system. And we were curious to see if this marker would be consistent at a young age in infants where we were observing their movement without asking them to move in any particular way. How does their spontaneous movement reflect their later gross motor function?
With that in mind, we created the BabyOSCAR tool to measure selective motor control from spontaneous movement behavior in infants at 3 months of age. BabyOSCAR stands for Baby Observational Selective Control Appraisal. There are 32 possible points for each independent joint movement that is noted in a 1-minute observation of spontaneous infant behavior. We will next show some examples of a specific test item and discuss the findings of our 3 papers testing the psychometric properties of the BabyOSCAR tool. So we wanted to show an example of one item on the test that would get a score of 1, which is knee extension. So here you'll see a series of babies showing a 1 for knee extension where they flex their hip and extend their knee. You see it there, and again. And this baby does it several times with the hip flexed and the knee extended. And this brief one here. Okay, so we're going to show those babies again. All right, so we'll see here this item of a 1, and we wanted to show later on in development what this skill translates to, which is moving around an environment. This case is a little girl with her new puppy where she's flexing and extending and doing different actions at once so she can navigate her environment, change directions, navigate this uneven surface.
Now we're going to look at some examples of clips where the infant did not score a 1 in the knee or they scored a 0, and for a couple of different reasons. Primarily that one joint is not moving in isolation of another, where the knee, in this case here, we will see they are flexing and extending at the knee, but they're only doing so when doing the same motion at the hip. So here the knee flexes at the same time that the hip does, and then when it extends, the hip is also extending at the same time. These masked flexion and extension patterns are sometimes referred to as synergy patterns, and that is the descriptor that you'll see on the BabyOSCAR sheet. Here's another nice example of a synergy pattern where the hip and the knee are flexing at the same time and extending at the same time together. There is variable presentation of this lack of selective control. In this case, the infant does show some signs of synergy where they're flexing and extending at the same time, In addition, we see characteristics of mirroring, where both legs and both lower extremities are doing the same thing at the same time. So in this case, they are not operating in isolation of one another. Instead, they are working together. And so neither of these are considered independent joint movements and are scored a 0 on the BabyOSCAR. In clinical practice, this kind of pattern may appear as gait deviations in older children. This video shows an example of a child with cerebral palsy going at normal speed and then slowed down a little bit, and you can observe instances of a lack of selectivity at the knee and hip and ankle joints. So when we look at gait deviations through this lens, we can see a lack of selectivity extending from infancy into some of the observations that we have of children at later ages with cerebral palsy. So in this first paper, looking at the convergent validity and reliability, we compared selective control at 10 to 16 weeks of age to the gross motor function classification system at least 2 years of age, so 2 or more years of age. And so we identified those without cerebral palsy and then those with different levels of cerebral palsy as measured by the GMFCS. And we saw a very strong relationship between their total BabyOSCAR score and their later gross motor function. So this tells us that their selective control or selective capacity at 3 months of age is very strongly correlated to their gross motor function at 2 or more years of age. In addition, we found that inter-rater and test-retest reliabilities were very good in the BabyOSCAR.
We also wanted to see how the ability at 3 months of age to isolate joint control was related to later outcome. And so we found that kids without CP scored between a 23 and a 32. And then all kids in our sample with spastic CP scored below a 22, or most kids I should say, 98% of them. And then we also found that when we divided those kids into 2 groups, the kids who have CP with GMFCS levels 1 and 2 versus GMFCS levels 3 to 5, we found that if they scored above a 13, that they were more likely to have GMFCS 1 to 2, and if they scored 13 or below, they were more likely to have GMFCS 3 to 5. Then we also wanted to look at body topography, and because the BabyOSCAR scores joints on both sides of the body, we could calculate an asymmetry score. While some of them had unilateral CP with less than 5 asymmetries, all children who had 5 asymmetries or more had unilateral CP.
While the findings between the relationship of independent joint control at 3 months of age and gross motor function at 2 years of age was very heartening and exciting for us to learn about, the psychometric properties of the BabyOSCAR were not fully realized using this methodology. Our colleague, Dr. Vanessa Barbosa, is an expert in Roche analysis and took this data and looked at it through that lens to determine the ways in which the items themselves were representative of the construct of the test. And so she found several key features of the BabyOSCAR were supported with Roche. First, looking at unidimensionality, she found that it was more appropriate for there to be 2 different subscales, arms and legs, and that they complemented each other very nicely. So where there was less resolution in the leg measure, there was greater resolution in the arm items. And so we are recommending that this tool be looked at overall in a clinical measure in a total score, but for research purposes, you may consider splitting them into arms and legs. In addition, the Roche allows for item and infant ranking, and so we looked at the difficulty rating of all of the items within the BabyOSCAR tool. And this allowed us to see the items that were relatively easy, or most infants were able to do them here on this end. So items such as elbow flexion extension, hip ab and adduction, and forearm pronation supination were behaviors that were present in a lot of the infants. Whereas when items got more difficult and fewer infants demonstrated them, we were able to identify tasks or behaviors such as hip and knee flexion and extension, shoulder flexion, and horizontal ABA deduction, which were more difficult. So in total, we found good item calibration reliability and good support for construct validity using this analysis method. Our current recommendation is that the BabyOSCAR tool be used in concert with the Prechtel General Movements Assessment for all infants who score absent fidgety movements. In addition, we recommend that any infants with the presence of a unilateral brain injury be scored with the BabyOSCAR to look for instances of asymmetry in their individual movements.
We're really excited to introduce this tool because we believe it addresses an important gap in the current research. There's been so much great work done on the early detection of cerebral palsy, but at this early age, under 5 months of age, there's a lack of tools that helps with good prognosis and body topography. So while we still need to do more work, we're excited about the possibility that this tool may help fill in some of those gaps for children that seem to have the highest likelihood of developing cerebral palsy. So we've learned a lot from doing this work, and of course we have more questions still. We'd like to test this out in a prospective sample, and we are also wanting to have this be used by clinicians and are understanding more about dissemination and training. So if you're interested in learning more about how to use this, we do have a manual that's available, but if you have even more questions after that, feel free to email us and reach out.